Good morning, Elliot, and thanks for joining us. I'm sorry I'm having some computer access issues here in my office, so I'm just doing it on my phone right now. But welcome. For those of you who don't know who Dr. Elliot is, he's a professor and vice chair of urology and director of reconstructive urology at the University of Minnesota. He was my mentor in Minneapolis, and one of the main reasons I went into reconstructive urology. He directs a fellowship in trauma and reconstruction, and is also a renowned authority in congenitalism. And so welcome.
Thank you, Dr. Sukumar. So Dr. Sukumar was one of our residents, and I couldn't be more proud of where he's ended up. I did medical school at Baylor after going to undergrad at Rice, so I have strong Houston ties. When I was a med student, Dr. Scardino was chair, and some of my inspiration came from Dr. Lerner and Dr. Boone, and of course, Dr. Coburn. So what a strong department, and it's good to see Dr. Sukumar ending up at my alma mater and doing the same kind of stuff I do. Today, I'm going to talk to you about something that's, pardon the catchphrase, but kind of near and dear to my heart. There's a lot of science, but there's also a lot of compassion in the talk. We're going to talk about a patient-centered approach to bladder management after spinal cord injury. I gave grand rounds at Houston Methodist a few months ago, and this talk is different from that, even though it was also on neurogenic bladder. So if anyone tuned in for that one, you can stay tuned in for this one. Nothing will be repeated. So what I'm going to show you is that in an ideal world, CIC is better than an indwelling catheter. But in reality, CIC discontinuation rates are high after spinal cord injury. UTIs and incontinence are really common. They're important quality of life issues for SCI patients, and they're common reasons for discontinuing CIC and moving over to an indwelling catheter. And when I say indwelling catheter, I mean either SP tube or urethral catheter. I'll show you that we can keep people on CIC longer if we give them proper support, which mostly means managing their UTIs, preventing their incontinence, and helping facilitate catheterization. And we'll talk about what that means to facilitate catheterization. I mean, it means creating metrophonophs, but it also means helping them find the catheter that works best for them. In the end, an SP tube is better for some people, and it's probably better if you put it in earlier rather than later, because you can do it before all the complications of an indwelling urethral catheter happen. So if CIC is not going to work, just go for an SP tube. And then lastly, patients are great teachers. Listen to them and you'll go far. So speaking of patients as great teachers, here are 3 patients who have consented to have their identities revealed in this talk, who've taught me a lot about spinal cord injury, Gabe, Kelsey, and Jackson. And you'll hear more about each of their stories as we move through the talk. So Jackson first. So Jackson is like the textbook patient. Jackson has this YouTube channel, which you should visit, called Jack in Action, that walks people with spinal cord injury through all the different ways they can really engage fully in life, whether it's how to drive a car, how to swim, how to walk with these robotic legs. Jack has a T10 spinal cord injury. He does CIC per urethra every 4 hours, and he's continent with ditropan. So, if you read Campbell's, this is your textbook spinal cord injury patient, and this is how they should be managed. And indeed, urologists favor CIC and anticholinergics for the management of neurogenic bladder after spinal cord injury. 84% of surveyed SUFU urologists preferred it. And there's good reasons, because there's a lot of concerns with indwelling catheter, like rare cases of bladder cancer, but much more common loss of bladder compliance, UTIs, urethral erosion, incontinence, and ulcers. In fact, after I'm done with this talk today, I'm going to go do a cystectomy on someone with a ulcer through their bulbar urethra to the perineum from long-term indwelling catheter. But is there just a referral bias? Are we only seeing the worst cases? And do some people do just fine with an indwelling catheter? I think this paper here using a VA population helps address that question of whether it's just a referral bias. At this point, this is kind of a classic article by Roger Domachowski back in 2000, looking at VA patients from the 80s and 90s. And there's going to be a few different slides here with graphs on each of them. On each one, indwelling catheter will be here in yellow, and that'll be SP tube or urethral catheter, spontaneous voiding in blue, and CIC in green. And then here's going to be years after injury, and then here's going to be the complication. So as you can see here, as you go further out in years after injury, bladder compliance declines with indwelling catheter and is preserved in those who spontaneously void or are on CIC. And even in a multivariate model controlling for age, level of injury, and completeness of injury, the risk ratio for decreased bladder compliance was still 9-fold higher with indwelling catheter. Similarly, for the outcome of any kind of urologic complication, meaning UTIs, stones, upper tract changes, or urethral complications, indwelling catheter and suprapubic tube have many more of these complications, especially over the long term. And finally, even going outside of urologic complications, the odds ratio of pressure ulcers and all-cause hospitalization is higher with indwelling catheter than any of the other management methods. And despite all this, if you query patients, those with an indwelling catheter have similar levels of satisfaction with life and perceived health status as those on CIC. So if they're having all of these complications, why are they just as happy? This is another way to look at some of these same findings, that in the systematic review, the incidence of all these different complications here in the left-hand column are higher with indwelling catheter through the urethra or suprapubic. So again, why doesn't everyone with spinal cord injury do CIC if they're able? And what we see here is that at acute discharge from the rehab, most quadriplegics are doing CIC. So when someone discharges from let's say they have a spinal cord injury, they spend several weeks in the hospital, they'll then move to acute rehab, where they learn, if able, to walk, to do CIC, basically how to manage their new spinal cord injury. And then usually in about 3 to 6, maybe 9 months, they move out of acute rehab and move back to home. When they leave acute rehab, most people are on CIC. And but yet when you send them home, the question is, do they stick with CIC when they're in the home environment? And I'm going to skip this multivariate model for now and cover that a little bit later. The answer is that they don't stick with the CIC long-term when they move home. So this is a great paper done by Ann Cameron using data from the National Spinal Cord Injury Database. And over time, people migrate from CIC to indwelling catheter with time. And the reason, in short, that the experience in acute rehab differs from long-term is that acute rehab is not the real world. In acute rehab, you've got dedicated nurses to help you with CIC and all the equipment you could need. When you get home, patients don't have those nurses with them. They need to be more independent. And then they start to develop some of these other complications like UTIs. And these are some of the things that drive them over towards indwelling catheter. This is a paper put together by Chris Elliot, who's at Stanford, and he used data from a project that I'm involved in called the Neurogenic Bladder Spinal Cord Injury Patient-Centered Outcomes Data Set, where we have about 1,400 patients with spinal cord injury across the country who were recruited through Facebook and from our clinics to fill out quality of life questionnaires for a year. We've written a few papers off of this. This one in particular shows that the predictors of staying with CIC over the long term are younger age, fewer years since injury, and then here's the important ones: male gender, non-obese, white race, and good upper extremity function. And of all of those, good upper extremity function is the best predictor. So if you discharge someone from acute rehab and they are a woman who has difficulty accessing her native urethra while in a wheelchair, and especially if she has poor upper extremity function, or if she's a woman and obese, making it even harder to get to her native urethra, then it's very unlikely that she's going to be successful with CIC per urethra over the long term. So I think what happens is that patients get discharged from acute rehab with unrealistic expectations about staying on CIC when they might have poor upper extremity function and maybe poor support at home to help them with CIC. And this causes them eventually to migrate over towards indwelling catheter. I didn't ask you at the beginning, Dr. Sukumar, Dr. Meyer, do you want me to pause throughout the talk for questions, or do you want me to take questions at the end?
I think we can do it at the end, Dr. Elliot.
Okay.
Yeah, that'll give you enough time to finish your talk.
Perfect. So indeed, the best predictor of staying with CIC is upper extremity function. This is a video that I just pulled off of YouTube on the internet, not one of my patients. But he's a really brave guy who also has a great YouTube channel showing how he manages his tetraplegia. He has partial upper extremity function. He's going to show you how he catheterizes through his native urethra. And I show you because it's not easy and it requires a lot of determination.
For me, what I tend to do is I scoot out of my chair a little bit here. And, I will just essentially undo my pants and get to, the area where I need to.
A lot of patients will use a bungee cord to help hold down the pants once they get them down. A lot of them will wear Velcro fly instead of a zipper to help get it down.
In order to do it. So that's kind of the general idea. If you're more advanced, I've seen some people that will use something that has like an elastic waistband, maybe like basketball shorts or sweatpants. That's fine. If you can pull those up and down, that's good. I've seen people use like a bungee cord to put on the front and pull them down so they can get to the entry point. So let me just go ahead and open this. So the first thing is, you'll see up here, it's got this little hole, which is nice. It's easy to hold. It also makes it a little bit easier to pull it apart. You can do your fingers like this and pull it. What I typically do is I'll actually use my teeth to pull those apart.
So, the video goes on, but the basic concept is that, CIC per urethra, especially in someone who's got tetraplegia, is not a 2-minute kind of thing. It can be like a 10-minute ordeal, not to mention if you're a woman and you have to transfer out of your wheelchair in order to do it.
For me,
So to get back to why patients move over to indwelling catheter, when surveyed, the number one reason for switching from CIC over to indwelling catheter is avoiding incontinence, looking for some relief from chronic urinary tract infections, and then also a desire for some independence from caregivers. And so, patients, that just like you and I, they don't want to be dependent on other people for all their cares. And if they can't do CIC themselves and someone else has to do it for them, that gets old pretty quickly and they're looking for some independence and they move over to an indwelling catheter. Similarly, a lot of times this survey showed that they'll end up in an ER, let's say multiple times per month with a UTI, and the ER doctors will tell them that they'll get fewer UTIs with an indwelling catheter, and they'll throw an indwelling catheter in. And then they show up at my clinic 2 years later, and they've been wearing an indwelling catheter, and no one has told them to do otherwise. It's important to understand that the level of spinal cord injury in the US is more often than not tetraplegic and incomplete. So that is why a lot of these patients cannot do CIC independently. So I wanted to talk next about urinary tract infections. Incontinence management is mostly with anticholinergics, Botox, and Augment. But how do we manage these urinary tract infections? And as the ER doctor suggested, does an indwelling catheter really help with the urinary tract infections? In this paper we wrote here, we use that spinal cord injury data set that I talked to you about earlier through the Neurogenic Bladder Research Group, where we surveyed almost 1,500 patients through Facebook and other means. And what we showed here is that we've got patients who void on their own, those who are incontinent either into a pad if they're a woman or a condom catheter if a man, those who manage with CIC, and those with an indwelling catheter. And as you move from the left to the right here, you see that as they move more closer towards, let's say, indwelling catheter, they get more UTIs. So more than 6 UTIs here in black versus 0 UTIs per year in this lighter gray. And these are self-reported urinary tract infections. We just asked them how many UTIs they had in the last year. These aren't necessarily culture confirmed. But then we also asked them, how many times were you hospitalized for a UTI? And I think that's probably a little better, more reliable measure. And indeed, the rate of hospitalization for UTI went up with a migration towards indwelling catheter. And when you do a multivariate model, indeed, indwelling catheter is about 4 times more likely to have urinary tract infections. But are these self-reported UTIs real, and do they really matter? Well, in terms of do they really matter, we asked several quality of life questions of these same patients. And here you'll see the rate of UTIs goes from 0 here up to 6 or more here, 0, 6 or more across here. And then these are different questions. UTI, did it limit my daily activities? I had an increase in bladder spasms and lower extremity spasms because of UTI. I avoided going out because of a UTI, and I had a UTI that would not go away. And this shows you that as the rate of patient-reported UTIs goes up, so do the limits on all of these activities of daily livings. So it would seem that even these self-reported UTIs are affecting quality of life. Whether they're real UTIs or not, we don't know, but the patient perceived symptoms of, painful bladder spasms, hematuria, foul smelling urine, cloudy urine that they interpret as being UTIs are definitely impacting their quality of life. In fact, UTIs and spinal cord injury, I call it kind of the lower back pain of reconstructive urology. It's the most common reason for ER visits, and it's about $29,000 in cost per admission. As I hinted at earlier, not all of these UTIs are real UTIs. In spinal cord injury, the NIH defines a UTI as greater than 10 to the 5th of a dominant organism, plus suprapubic or flank pain, new or worsening incontinence, fever, increased spasticity, autonomic dysreflexia, malaise, lethargy, or unease, which is that last one is kind of the hardest one to pin down. But if you randomly culture patients with spinal cord injury, it comes up positive 2/3 of the time. If you ask patients whether they feel like they have a UTI, and then you investigate whether they really have a UTI, there's actually other things to explain their symptoms almost half the time, like fecal impaction, for instance. And what this means is that there's a lot of over and under treatment of UTIs. So how do we try to work up UTIs and manage them? Not acutely, But when I see patients in the clinic who are having multiple UTIs, what do? So we do a workup if there's 3 or more UTIs in a year, patient reported or real. We do that with a cysto to look for, pockets of mucus or a tumor that might be masquerading as a UTI, because, it could cause bladder spasms and hematuria. We do a renal bladder ultrasound, and we do video urodynamics. And how do we try to prevent UTIs? We go over proper catheterization technique. We make sure we're optimizing bladder pressure management with Botox or Anticholinergics. We do bladder irrigation. Dr. Hoofsman at Mayo Clinic showed that the more they irrigate, the fewer UTIs they get. I give I do some vinegar installation overnight. If that doesn't work, we progress to gentamicin installation. The evidence isn't great, but if it helps prevent some people from moving over to prophylactic daily oral antibiotics, I'll do it. And I'll go over in the next slide a little bit more about why I do it. And it gets to this thing that I call symptomatic asymptomatic bacteriuria. Because if something's not a UTI, but they have a positive urine culture, that's called bacteriuria. And people call it asymptomatic bacteriuria to differentiate it from a UTI. But a lot of these patients, I would say, fall into this gray zone, what you can call symptomatic asymptomatic bacteriuria, or just call it funky urine, which is that they have a positive urine culture. They don't meet our definition of a UTI because they don't have a fever, hematuria, and some of these other things, but they're very bothered by this cloudy, malodorous urine, and it doesn't drain well. And so they seek treatment. And so this is why I'm looking at treatments like vinegar and gent installation, because I think to ignore this funky urine both ignores how it impacts the patient's quality of life negatively, because they don't like the bad smell and they're looking for a treatment, but it also helps prevent overtreatment, because if they seek care from somebody else, they're probably going to get oral antibiotics. So I think there's a really good role for some of these therapies like gent installation that fall short of oral antibiotics to help treat this funky urine. Spinal cord injured people really just want to fully engage in life, just like you and I. When you survey what's important to them, there on the left column, you see that the things that are important to them are the same things that are important to you and me. Things like friends and family, their general health, having a job, being able to enjoy time with friends. And on the right-hand side, when you ask them what's most important to them in terms of their health priorities, bowel and bladder function is number 1, and sexual function is number 3. And all of that comes before walking. So as urologists, we really have a big role to play in helping preserve their quality of life. And as we've gone over, in the short term, indwelling catheter is really easy and CIC is really hard. But we also know that if we can keep people on CIC, then we can help prevent some of these complications. And so now I'll go over a little bit the role of the urologist in helping keep the patient engaged in care and helping keep them on CIC when possible. This shows that spinal cord injury people are not entirely satisfied with CIC. In green is their quality of life. Basically, are you satisfied with your bladder management or not? And in red is unhappy. This again comes from our Neurogenic Bladder Research Group registry. And we see that those on CIC are the least happy. Even though I've shown you before, they have fewer complications. Those with an indwelling catheter or surgery are happier. And I think this gets to some of the things we talked about earlier, like those on CIC are more likely to have incontinence or have problems perceived to be due to the CIC, like infections, and it's just, or problems with independence, and it's just easier to move over to an indwelling catheter. it takes a lot of work to stay on CIC. And, as surgeons, you and I can help them stay on CIC. So one thing we can do is help them find the right catheter system. When I started out doing this stuff, everybody got this catheter here on the left. And everybody was told to use the same catheter for a week and wash it because, Lapida's study showed that that's just as good as a single-use catheter. But the truth is that a lot of patients find it a lot easier to use a single-use catheter. A lot of them find it easier to use catheters that are pre-attached to a bag because they might not have good enough hand function to hold a urinal. So I say, let them try a variety of different catheters. I've got a suitcase of different catheters that my nurse shows to the patient when they start out on CIC. And then we connect them with the catheter rep and they try a variety of different ones and we find out what works well for them. You can also help them stay dry by doing bladder augmentation. The point here is don't just give them anticholinergics and Botox and be afraid to take the next step, which would be bladder augmentation. If we don't move quickly enough to surgery, they're just going to have problems with incontinence and UTIs and eventually move over to an indwelling catheter. We can
Dr.
also,
Elliot,
yeah.
I'm sorry to interrupt. Speaking of the indwelling catheter, and on that slide, many slides back where you had the graft, we didn't see suprapubic tube kind of parsed out. Was that included in the indwelling catheter?
It was, yeah.
Thanks so much.
On this one, it is. So just a couple more slides here. We can also, not only can we help using surgery to help with bladder storage, we can also use surgery to help with bladder emptying. So, a catheterizable stoma, whether a Mitrofanoff or a Monti, can help, especially women who are in a wheelchair, do intermittent cathing without having to shift out of their wheelchair. And we should offer that sooner rather than later so they don't progress over to an indwelling catheter. Here's another video, again, not my patient, off of YouTube, a woman with quadriplegia showing you how she does intermittent cathing through a stoma.
Everybody asks me, you're quad and you're girl, how do you cath on your own? So here's your answer. Just ignore my stomach scar, it's a different story. Not related to the Mitrofanoff, which is not a suprapubic tube. I do have quad hands, so it takes a little bit longer than an able-bodied person. Part is don't touch the tube.
You can see there's no way she'd be able to catheterize per urethra with what she calls her quad hands, but the Mitrofanoff facilitates her catheterizing and she can do it independently. So again, don't be afraid to progress to surgery to help them do intermittent cathing. So in summary, our job is to optimize storage and emptying to prevent and manage UTIs. And if we do this and we meet with the patients early and often, we can help keep them on CIC. And then use some of these predictors that we talked about earlier to figure out who's probably not going to do well with CIC and help them get over to an SP tube early, I think, in order to prevent urethral erosion and a few other complications that are unique to indwelling urethral catheter. The last thing is to listen to the patient's needs and give them patient-specific care. To go back to the patients you met at the beginning of the talk, this is, again, Jackson. I told you he was the textbook patient. He's also my textbook patient because he didn't do well on CIC and oxybutynin forever. Eventually, he started to develop incontinence and we had to switch over to botulinum toxin injections. He now has a bit of a urethral stricture at the membranous urethra from all the cathing with the straight cath. And so we've had to move over to a Coude catheter. Now, if he wasn't having annual follow-up with a urologist, I think a lot of this would get missed. He'd just get told he needs to switch over to an indwelling catheter. So we always do annual visits with our patients. And then last slide, it goes back to Kelsey and Gabe. So Kelsey was about 21, 22 years old. When I met her, she had been out with some friends on Lake Superior at a cabin and dove into the water and hit her head and suffered a spinal cord injury in about 2012, so almost 10 years ago. I met her when I was pretty new at managing spinal cord injury. And she was only at the time a few weeks out of acute rehab. She might have only been like 3-4 months out of her spinal cord injury, but she was quadriplegic. And I told Kelsey, where this was probably headed. I told Kelsey we would do urodynamics after she was out of the period of spinal shock, and that at a year after we repeated her urodynamics, we could talk about urinary diversion options, including a catheterizable channel. But Kelsey came saying, I want my cath channel right now. She said, I don't know why you want to make me wait a whole year. I am done with having these nurses have to cath me while I'm laying flat on a bed. I said, well, if I do your cath channel right now, your urodynamics shows that you have a flaccid bladder, but you're probably going to develop a tight bladder later on. And so, I was at a bit of a crossroads. Do I augment her or just give her a cath channel? And, I listened to the patient. She wanted the surgery right now. I knew she was eventually going to develop detrusor overactivity. And so we did a cath channel and an augment, even though, the urodynamics were still flaccid bladder. She sent me this picture of her winning Miss Wheelchair Minnesota, and now she runs her own company, and she's in a really good place in life. And she sent me this Christmas card saying, I couldn't have done it if you didn't help make me dry. So she taught me something about sometimes just intervening with the cath channel earlier. She probably would have ended up with an indwelling catheter if I hadn't been willing to operate on her sooner. And then Gabe taught me a lot too. Gabe, he is also tetraplegic. He has his own rock band where he's the lead singer. And Gabe was managing his bladder with a condom catheter, and he actually still does. And he voids into the condom catheter, 10, 20 times a day. And he gets autonomic dysreflexia when it's time to void. And I met him also like 10 years ago, and I completely freaked out to hear he was having autonomic dysreflexia like 10 times a day, but he'd been doing this for 5 years, and he was pretty comfortable with it. The AD was pretty mild, and I talked to him about all kinds of other things like an indwelling suprapubic tube. But he insisted on staying with a condom catheter. I've continued to meet with him, and 10 years later, he's still doing fine with a condom catheter. His kidneys are in good shape. He's not having UTIs. And so, why should I push him over to something more invasive? We just follow him closely and we'll intervene in the future if we have to. So, listen to the patients. I think they can teach you a ton, especially when they have a condition like spinal cord injury that you and I have had absolutely no experience with. So thanks for your time. I can take any questions.
Right. Any questions for Dr. Elliot? I have a few, but I'll wait for the group.
John, this is Mike Coburn. Thank you so much for doing this. It's tremendously valuable for us and a really interesting set of data and great recommendations that really affect all of our urological practices. You really spoke very eloquently about the challenges of chronic indwelling Foleys, both in male and female patients. And in the male, we see this progressive acquired hypospadias that can be very damaging. and very hard to repair. And, we talk about the risk of urethral inflammatory disease with the chronic indwelling urethral catheter in the male, like the potential for urethritis or urethral abscesses and prostatitis, prostatic abscesses. What's the data there? What does that form of morbidity really look like in men who, for whatever reason, prefer a chronic urethral Foley?
Thanks, Dr. Coburn, and thanks for having me today. I think the best we've got is this systematic review that Dr. Cameron did, showing that there's an increased incidence of, as you said, urethral strictures, epididymitis, and these things correlate with an indwelling urethral catheter, and they don't get them quite as often with a suprapubic tube. So these are some of the complications that are unique to the urethral indwelling catheter. What the percentage rates are, I don't recall, just that they are unique to urethral rather than suprapubic catheter.
And in the female, there's this tendency for non-urologists to keep going to larger and larger urethral catheters because of progressive stretching of the urethra, and then this kind of like stovepipe urethra that causes incontinence. And I've seen people ultimately come in with like a 26 French Foley, and the goal is to have a big enough catheter to kind of plug the space around it, which clearly works in the opposite direction. Thoughts on that for the female patient?
Yeah, and it's not unique to spinal cord injured patients. Obviously, it happens in women in long-term nursing care, nursing homes. And as you said, they'll go up in catheter size. They'll also go up in balloon size because the balloon starts to fall out if it's only a 10 cc balloon. And that's, in my experience, a lot more common if they're obese as well, because I think it increases the speed with which they get this pressure necrosis of the urethra, and as well as the sphincter around the urethra. Eventually, this progresses to exposed pubic bone because the catheter gets pinched between the wheelchair and the inferior margin of their pubic symphysis, and they'll get a pubic osteomyelitis. And we've had to operate on those with pubectomy and diversion. But if you catch it early enough, one of my favorite operations, even though I do almost no transvaginal surgery, one of the few transvaginal operations I do is a transvaginal bladder neck closure. And there's a great AUA video of Eric Robner doing this, if you want to find it from one of the previous meetings. So you can do a transvaginal bladder neck closure and place a suprapubic tube. And this is how I've managed these women if they're not candidates for diversion, if you catch it before, of course, the pubectomy stage.
That's very helpful. Thanks.
I have a couple of questions, Dr. Elliot. One had to do with management of neurogenic bowel, concurrent management of neurogenic bowel in these patients. As we know, bowel function can markedly change after spinal cord injury. And so I was curious about your thoughts on concurrent management, both conservative and surgical management.
Yeah, thanks, Dr. Sukumar. The management of the neurogenic bladder neurogenic bowel frequently falls in our lap. And it can be frustrating because why doesn't GI want to take care of it? Why doesn't colorectal want to take care of it? But I've tried to move past that frustration and just focus on the patient's needs and, just take care of it because no one else will. And it's unfortunate, but it's the truth. So I think that the biggest change in neurogenic bowel management lately has been Peristine. And I have no financial interest in Peristine, Peristeen. So Peristine is a way for patients to give themselves a balloon enema. If you've ever watched someone give themselves a balloon enema using a Foley catheter, it's really difficult. They have to put, like a 24 French Foley in their rectum. They inflate the balloon. The reason you inflate the balloon is a lot of them don't have the rectal tone or the anal sphincter tone to hold an enema in. And the balloon inflates to help hold the catheter in and to help block the enema from washing out right away. And then they put the saline or water through the Foley catheter. And it's just like, it's one too many things for them to have to manipulate all at once. But the Peristine incorporates all of that into one device, which they can easily manipulate with a little hand control system. And that's helped me avoid quite as many ACE operations, as well as Chait tubes. And I'm sure the pediatric urologists on the call here probably have some experience with Peristine as well.
Awesome. And then sorry, go ahead.
Oh, Dr. I was going to ask you, could you sorry, technical difficulties. So on you doing the vinegar and the gentamicin installations, can you talk about how you're doing that, whether they're doing CIC versus indwelling, is it
Right.
capping, versus how that process works?
Yeah, that's a great question. It's really impossible, I think, to do the vinegar and the gent very well if they've got an indwelling catheter. There's the rare patient who can hold their urine with an indwelling catheter capped for 2 or 3 hours for proper dwell time. Most of them, if you cap it for 30 minutes, they've got a small bladder and they start to get bad spasms. But if they've got decent bladder capacity and indwelling catheter, then we flush the bladder empty and we instill the vinegar or the gent, and then we cap it for a couple of hours. More commonly, we're doing this in patients on CIC. So we have them do their last cath at night before they go to bed. We have them do their saline or tap water irrigation of the bladder with 240 cc's. And then we have them instill the gent or the acetic acid before they go to bed, plug the catheter, and then they just empty it the next time they empty their bladder. They're only putting about 30 cc's into the bladder using the solution, so it's not a big volume. And if you want to see the exact recipe for how to make this, you can search on Google for Gillette, which is Gillette, and vinegar bladder wash or gentamicin bladder. Gillette is where I have my spina bifida practice. It's a hospital in town.
All right, and then I just have one last question, Dr. Elliot. Just management of stress incontinence in these patients. I'm sure we'll touch upon this a little bit more tomorrow when we do the urodynamic session, but if you can touch briefly upon the management of stress incontinence in patients with spinal cord injury and neurogenic bladder.
Yeah, so I try to avoid bladder neck closure if at all possible, because I like to have an emergency way to put a catheter in if they can't access a Mitrofanov, for instance. Even these women that I do the bladder neck closure on an SP tube, it makes me nervous because if they lose access to their SP tube, it's a disaster. But the short answer is that in women, I prefer a fascial sling, pubovaginal sling, using either rectus fascia or fascia from their thigh, the fascia lata. And in men, I'm usually more likely to do a bladder neck AUS, and we can do that robotically. I have not done urethral slings in men because I find that it makes CIC more difficult because it kind of changes the angle of their urethra.
Sean, it's Mike Coburn again.
Asked,
can I ask a sort of more general question since we have a few minutes left? You know, the whole area, obviously, which has emerged and continues to increase in importance of transition medicine and the transition of the pediatric spina bifida and or other sort of urologic congenital anomaly patient into the adult sphere, obviously is complicated. There's been a great deal written about it. There are great efforts at many institutions. I think that our transition medicine approach and our movement of the pediatric spina bifida and similar patients into our adult urology realm is not very well developed yet at our institution. It's something that we're hoping to pursue. But, you know, could you give us your thoughts on sort of best practices for this transition medicine approach and how to bring the pediatric patient at the appropriate age into the adult urological environment in a way that's most effective. I mean, you obviously have in many ways mastered this, and I'd love to hear your thoughts on sort of best practices for that whole initiative.
Sure, I've got a whole talk on it, and if I was more facile, I would pull up the summary slide from that talk. But let me give you the take-home message: is that in general, transition happens very poorly across the country. Most patients don't have a successful transition. When patients do transition, there's a few different models, and I put them in different buckets. You can have patients, some patients will stay with their pediatric urologist forever. Other patients will transition to an adult urologist who sees them in the pediatric hospital. Others will transition to an adult hospital, and the pediatric urologist has an adult long-term follow-up clinic in the in the adult hospital because they understand the disease better than the adult urologists. Other patients will totally change hospital systems to go to a center of excellence. That might be like, let's say, someone changes from Texas Children's over to Baylor College of Medicine to see Dr. Sukumar there because they might not have such a clinic in Texas Children's, and so they totally change hospital systems. And another model would be if you have what we have at Gillette, which is a pediatric hospital in the Twin Cities, where there's a children's hospital, and then about a mile away from the children's hospital, we have a brick and mortar adult longitudinal follow-up clinic, which is owned by Gillette, but is only for adult care. And some adult providers are working there. It's some peds doctors because for instance, the pediatric neurosurgeons understand shunt management a lot better than the adult neurosurgeons. And then I go there as an adult urologist. We have, I think, one of the best examples of this coordinated multidisciplinary clinic, because a lot of these multidisciplinary clinics are kind of what I call pop-up clinics that happen once a month, where everybody converges either physically or virtually to take care of the patient once a month. But we actually have this brick and mortar clinic where patients can go every day of the month. The clinic operates. In fact, there's urology there every day of the month. It's a nurse practitioner most of the month, and then I'm there twice a month. And neurosurgery is there a couple of times a month. But there's med peds there, and wheelchair fitting, and social work, and wound care, and the nurse practitioner for urology every day of the month. And I think that's really the ideal model. And honestly, it works well for me too, because then when I go once or twice a month, I'm really seeing the patients that need MD level care and possibly a surgery, because my nurse practitioner has kind of vetted all of the non-operative patients during the rest of the month.
Great, thanks for the outline on that. Obviously it's an area where many institutions still have a long way to go to, to provide the level of care that patients should expect.
Mike, this is Chester. You mind if I add, I have to run to the OR, but can I add that? I mean, I think unfortunately one of the biggest limitations is insurance coverage when they get to the adult age. And that, I think, is unfortunately the driving factor for why things haven't changed very much. I think once that's solved, and I see Sean agrees that once that's solved, I think the care will improve a lot. But until then, you're going to be stuck with a mix of coverage types. And that's why I think a lot of times they stay within the children's hospital system, because they can't get coverage elsewhere. So thanks. I got to go. Thanks.
Yeah.
Thanks, Chester. Thanks for joining. Appreciate it.
Well, that's perfect, Chester. The clinic at which I work at Gillette, I mean, just like you said, for them, it's kind of mission centric. They provide this adult clinic because it fits their mission, and it's a loss leader for them, but they know it brings in the patients on the pediatric side because they know they'll have this long-term adult care.
Great. There's two other questions, Dr. Elliot, in the chat box to the residents. Jenna and Pratik asked separate questions. Jenna has asked about about YouTube, and if you could touch upon how you're using YouTube for patient education in your clinic.
Not enough, and I should use it more. It's probably just one of these things where I'm so busy on a day-to-day basis that I don't stop to think about how I could make my clinic work better using technology. I do direct them to the Neurogenic Bladder Research Group website, where we have some patient education videos. I have a video online on YouTube about what is a neurogenic bladder after spinal cord injury. So I'll direct a lot of my newly injured patients to that video that gives them a lot of the background of how detrusor overactivity happens and what's the difference between a flaccid and an overactive bladder. And that saves me some time. But I could do a lot more using YouTube to teach them how to self-cath, to show them the tips and tricks about like the bungee cord and other things like that. And I don't do it often enough.
And I definitely want to emphasize, at least from a surgeon standpoint, from an education standpoint, your Turns channel on YouTube has been a great resource for the residents, and even during my fellowship. So I want to emphasize that for the residents. It's called the TURNS Turns channel. And then Pratik asks, can you talk about when you introduce to patients the idea of a catheterizable channel on their initial visit, or only if they are unhappy with CIC?
If they can do CIC per urethra, then we'll stick with that. In men, as long as they have good hand function, they can usually do CIC per urethra. In a woman, I'll find out if she's doing CIC per urethra and how much help it takes. And I'll ask them about, how much help they have at home and if it's going to be feasible long-term. And I'll talk to them about other options at that first visit if I get the impression it's probably not going to work long-term.
All right. Any other questions, Dr. Elliot? Well, Dr. Elliot, thanks a lot for doing this. We really appreciate you taking the time off to give us this lecture. And just for everyone who's on the call, Dr. Elliot's going to spend an hour tomorrow morning between 7 and 8 o'clock for an interactive session with the residents dealing with complex urodynamics cases. And so please do join us tomorrow morning. Thank you, Dr. Elliot.
Thank you, Dr. Sukumar. It's a real honor.
Sean, thanks again. That was superb. Really appreciate it.
You bet, Mike. Have a good day.
Take care.
Thank you, sir.
See you tomorrow.
Okay.